There we go. Hello and welcome all to Care Not Cuff's monthly dispatch. Each month, we invite presenters from around the country to share their work at the intersection of mental health and mass incarceration and how they are building safer, equitable systems of care for those facing mental illness, substance use, and justice involvement. We would like to recognize and thank Rocky Mountain Health Plan's Mental Health Colorado's elite sponsor of the year. Before we get started, we want to take a moment to encourage our Colorado audience to write to their representatives to support funding for a variety of Mental Health Colorado supported bills, including House Bill 1355, measures to reduce the competency waitlist. You can find an email template alongside resources for finding your representatives at our website, and I'll also drop the link in the chat here. Let's see. There we go. So this evening, we are thrilled to have Dr. Catherine Camfield and JJ Keller join us from the Beat Meth team. We may also be joined later in the evening by Dr. Scott Simpson. Beat Meth is a comprehensive systems level intervention framework for methamphetamine addiction, aiming to treat methamphetamine use early and to prevent overdose. With a grant from the Centers for Disease Control, the team has worked to define diagnostic criteria for methamphetamine-induced psychosis, train Denver Health staff on available treatments in the neurobiology of addiction, developed treatment pathways, supported the peer recovery model, and is conducting a randomized control trial. We will have time for questions after the presentation. Please feel free to ask questions throughout using the Q&A feature located at the bottom of your Zoom window. And with that, I will turn it over to the Beat Meth team.
Great. So I'm Catherine Camfield. I am a psychiatrist that primarily works in the psychiatric emergency department at Denver Health. And I'm also board certified in addiction medicine. As you can imagine, in the emergency department, because of the nature of methamphetamine intoxication, we have a lot of presentations related to that. And I'll let JJ introduce himself and his role at Denver Health.
Thanks, Katie. Hi, everyone. I'm JJ Keller. I'm one of the peer recovery coaches or peer support specialists here at Denver Health. So I part of the Beat Meth team as well, and just run support groups for people, just helping them get connected to care with any substance, whether it's meth, opioids, alcohol use disorder, just making sure that they're getting connected to care, running support groups, and connecting them to resources.
Thanks, JJ. So yes, we're very excited to be here. What we'll do is I'll start by doing a PowerPoint presentation that just goes through some of what we're doing with Beat Meth and why we're doing it, and hopefully some interventions that can help people in our community. And then I'll turn it over to JJ, who can speak more to his experience, as well as ways that he's working to help people in our community and at Denver Health. So without further ado, we'll get started. Oops. There we go. Okay. So, why is this work so important, right? So, these are the overdose deaths in Colorado since 2001. And as you can see, the last couple years, really since 2019, there's been a spike in overdose deaths. That top line in gray is death secondary to opioid use, right? So we're all probably aware how fentanyl is kind of ravaging the communities right now. Like there's a lot of people dying from overdose. But what a lot of people don't realize is that you can also die from methamphetamine overdose, and those overdose deaths are increasing significantly as well. So that's that second line in orange, right? And I think it's a common misconception regarding methamphetamine use that a lot of people think you can't die from overdose, right? Both patients and providers don't realize that, right? And so, and more complicated, right, is people are using methamphetamine and fentanyl together, right? And so it's really, can be really dangerous, right? And so, and something else to keep in mind is that, those that overdose from opioids and are in the hospital, 60 to 70% of those people at Denver Health are able to get connected to outpatient services, right? Whereas those that are in the hospital for methamphetamine intoxication or overdose, only 10 to 15% of those at Denver Health are getting connected to outpatient substance use resources, right? So even though, we are seeing this growing trend of meth overdoses. People aren't getting connected to the treatment they need. So, and then this is just another graphic to highlight, right? Just overdose deaths in general, right? Throughout Colorado. And then these are for non-cocaine stimulant overdose deaths, right? So typically that's considered to be methamphetamine. So what are our objectives today, right? We're talking a little about the neurobiology of methamphetamine addiction, the work we're doing through Beat Meth to try and improve outcomes for those struggling with methamphetamine addiction, and then specifically contingency management, which is one of the more effective interventions that we have in our toolkit. So what's happening in the brain, right? So, this image on the left is a model of normal dopamine transmission, right? So if you imagine those little yellow gold dots, right, are dopamine molecules. So with methamphetamine use, basically your brain is getting flooded with dopamine, right? So it's twofold, right? So dopamine is being blocked from being reabsorbed into the neurons, right? So it's staying kind of in what we call the synapse, right? And then also methamphetamine promotes the release of dopamine, right? So it's really kind of a two-hit as far as what makes methamphetamine so potent and so addictive. And so, right, when your brain is getting flooded with dopamine like this, right, there's actually changes in your brain that are occurring that makes it more difficult to engage in treatment, right? The reward system itself, right, when it's getting flooded that much, is going to get reinforced, right? And methamphetamine is a very potent reinforcer, right? And then also it's neurotoxic, right? So it can affect things like memory and mood regulation, emotional regulation, people's ability to really engage in care and just neurocognitive functioning, right? And so these are concrete changes that are happening in the brain. It's not just some people assume with addiction, oh, it's just some moral dilemma, right? No, these are actual changes in the brain that are happening that make it so addictive. And so what is this Beat Meth initiative that we've started at Denver Health, right? And so it's a strategy to try and treat and engage patients that are struggling with methamphetamine use disorder. And there's lots of different branches, as Michaela said in the introduction. It's very comprehensive, right? And what that might look like from the patient perspective, right, is that there's going to be changes to treatment protocols, standard work referrals, we're monitoring outcomes, right? And I'll talk more about some of the different things we're doing. And so this is kind of what we see for the continuum of care of those struggling with methamphetamine use disorder, right? And so the second bar here, I don't know, can you guys see my mouse when I move it? Does that show up?
Yep.
Okay, so the second bar here, it's usually kind of highlighted, but so that's what we're kind of focused on right now. But in general, we want to engage people along this continuum and keep people in this continuum, right? Ideally, patients that are identified as having meth use disorder are able to get referred to care, and then they can get, initiated with this care. They're able to be retained in care, and then they, over time are able to achieve remission, right? And, ideally, those bars would all be the same height, right? But over time, people fall out for whatever reason, right? And so we want to figure out how we can decrease barriers, right, for this continuum of care, and also define like effective interventions, right? And so doctors Emily Bacon and Ryan Lowe in particular are really focused on developing surveillance models for patients that are at all of these different stages, right? Because it's really important to identify patients where they are along the stages and how to move them through this continuum. Oh, there it is. And so what are some challenges we're facing, right, when we're just trying to identify patients and the need for this, right? One is, just getting accurate data, right? So, for example, if we were to just pull ICD-10 codes from an electronic medical record, right? Methamphetamine use disorder is going to be the same code as caffeine use disorder or other stimulants, right? So, we need to do more than just, from a surveillance standpoint to make sure it's accurate than just pull out, the numbers. And so one thing that we tried was going to the different psychiatric services and having them identify when they thought methamphetamine psychosis was likely present for patients that were presenting with psychosis, right? And actually like 11% of encounters where people actually answered this question, people were concerned that this was a methamphetamine-induced psychosis, right? So that's an improvement, right, as far as the numbers, right? But it's still missing those that maybe, hadn't been tested yet, or like in the emergency department, we often don't know exactly what's happening yet. We haven't had the time, right? So it's still not catching everyone. And so they're trying this new model of using what they're calling methamphetamine markers to identify patients with methamphetamine use. And the idea here is that, there's a combination of, well, there's markers and then preferably a combination of markers that are going to give us the most accurate picture of who is struggling with methamphetamine use, right? And, on one end of the spectrum on the left here, it's, clinical impression and positive assessment has been shown to be most accurate, whereas, just pulling out meth related terms and notes or other things are much less accurate, right? And so we're just trying to find novel ways to figure out what the need is in our community and in order to be able to address it. And so what does the Beat Meth initiative look like on the treatment end, right? The overall goal for all of this is improving care for everyone, right? And so is that, so what things that we've done, right, or at the team has done is there's more intake groups at the substance use clinic on the Denver Health campus, right? We're advertising treatment to patients. There's a lot of staff education, right? Because I think there's a lot of stigma among staff as well about methamphetamine use. We're trying to do more protocolized treatments, and that way we can expand it to other services like in the emergency department, at Denver Cares, other parts of the hospital system. And then, at the same time, we're trying to advance the science of treatment, right? So there's a randomized control trial that we've already started. They're doing frequent program evaluations just to see where things can be improved or changed, right? And so, so that's kind of how it looks on the treatment end. An example of how we have kind of had to pivot, right, through, program evaluations, is, transitioning from inpatient to Denver Cares, right? So this pilot first started, earlier in 2020, where there was a specific meth pathway that went to inpatient, right? And so the inpatient psychiatric unit for those struggling with methamphetamine-induced psychosis, right? And so if they went on this methamphetamine pathway, they would get certain protocolized treatments, right? And then also get connected to outpatient care while they were inpatient, and to have kind of a warm handoff to help with transition of care, right? And it was shown to be effective in increasing follow-up within 30 days. The problem is, as we all know, with 2020 is that COVID hit, right? And so that really limited admissions to the inpatient unit. The capacity, nursing staffing was really spread thin and cut short, right? So then, by 2022, what they started doing is partnering with Denver Cares, which, if you're not familiar, it's a withdrawal management facility. It's about 2 blocks from Denver Health. And they manage intoxication and withdrawal of, multiple substances, including alcohol and opiates. And then now they have methamphetamine protocols as well. Right. And so you've seen that we've been able to really re-engage patients, and this is how we're able to hopefully get people into long-term care as well. And this is just, I don't have to go into this a ton, but some more specifics about the randomized control trial we're doing right now. But basically, people are being assigned dedicated care navigators to help them address a lot of the barriers that are keeping them out of treatment, right? And using that as a primary outcome, like linkage to treatment within 30 days. And so what's even out there as far as methamphetamine addiction treatment, right? Unfortunately, compared to opiate use disorder, we don't have good evidence-based medication options, right? So the pharmacology, there's starting to be some promising studies, right? But the evidence is still very limited. And so, opiate use disorder, right? There's methadone and there's Suboxone, and, there's these really effective, widely adopted treatments, right? We don't really have that for stimulant use disorder, particularly methamphetamine use disorder, right? And so, what we do have, though, is more psychotherapeutic interventions that have been shown to be effective. So contingency management is probably the most effective. It's been well studied for many decades. And so that's what we'll talk more about today. And then as far as, there's also cognitive behavioral therapy, motivational interviewing, other things that can be effective, right? And so what is contingency management? So this is a behavioral intervention in which material incentives are delivered contingent based on desired behaviors, right? And so, and like I said, this has been well studied and shown to be really effective. So what does this look like, right? In kind of a simplified summary of it would be, for example, someone who is seeking care for substance use disorder, right? In this case, methamphetamine. They would give a urine drug screen at their appointment. And if that's negative, then they get to spin a wheel, or like draw from a fishbowl, where they get to like win reinforcing items, right? And so I think there's this stigma that people have where it's, oh, you're just paying people not to use substances. But really there's a lot more science to it, which I'll go into. And it, basically, just like substances light up certain parts of the brain, right? So does contingency management, right? And so for it to be effective, you have to follow certain protocols, and steps to make it most effective. And how does this work, right? So it's a behavioral intervention, like I mentioned, right? So it's based on this idea of operant conditioning. And was what was well studied by Pavlov. I think Scott put those pictures of Pavlov's dogs, right? Where it's been shown that positive reinforcement and variable schedule of reinforcement is most effective for behavior change. So simplified is, operant conditioning is behaviors are shaped by consequences, right? So if there are good or bad consequences, that can increase or decrease a behavior. So in this case, a positive reinforcement is getting to spin the wheel, right? And the behavior is having a negative drug screen. And the variable schedule of reinforcement is, like, for example, on a wheel, someone might just land on a positive quote, right? Or they may land on $30, right? They don't know what they're going to get. And the same thing drawing out of a fishbowl, right? And another important point is this idea of delayed discounting, right? So for anyone that's involved in a behavioral intervention, right? If the reward is delayed, it will be less effective than if the reward is given right away, right? And with substance use disorders, right, people tend to be a little more impulsive and, they're gonna choose like the smaller, more immediate rewards, which is often getting the effects of the substance versus these, longer term reinforcements, right? Which is like maintaining good health, staying out of jail, maintaining family relationships, right? Like, those feel very distant, right? Than these more immediate rewards. So this is also kind of based on that idea. And this is just a slide showing that all the studies that contingency management is very effective. And who can benefit from contingency management? Really anyone with a stimulant use disorder, and also other substance use disorders as well. Just because there's not a good pharmacological intervention for stimulants, then contingency management is our best option. But it's okay if they also have alcohol use disorder, they also have opiate use disorder, right? Or if they're getting treatment for like their depression or PTSD, right? They can be on psychiatric medications. They can be in individualized therapy. Like a lot of our patients have a trauma history, right? So if they're in their own individual trauma-focused therapy, they can still be involved in this contingency management. And contingency management, it can be done one-on-one or in groups, right? But it has been shown to be more effective in groups because there's this extra motivational layer of like seeing your peers win and you winning in front of peers, right? That can be helpful. And then how do we refer to contingency management, right? So we have a program at Denver Health, which JJ will speak more to, where they can just walk in, or they can go to this group on Wednesday mornings at 10 a.m. You can also walk in Tuesday, Thursday mornings before 8 a.m. There's a CAM, which is Centers for Addiction Medicine community line that anyone can call. And also, there's groups outside of Denver Health, obviously, right? So there's Crystal Meth Anonymous or other AA related groups, other peer support groups, right? And this is just examples of flyers that we give out to our patients and it includes like JJ's group and then the information on where it's located. And before I hand things over to JJ, one part of this grant has been doing some qualitative work as well and getting the patient perspective, because I think so many times in studies, we just look at the provider side and aren't hearing from the patient experience, right? And so I'll just read a couple of these quotes because I think they can be pretty powerful. So if you plant that seed, it'll grow. It might not be an overnight, same day thing, but over time they might say, oh, maybe I do need some treatment. I keep showing up here. And just letting them know that it's out there when they're in the ED, letting people know the resources are out there, giving them resources, even if they throw it away, it would always be helpful to have something to call in a moment of desperation. And lastly, I get a seat at the table. I can make my own decisions. I don't have probation officers making my decisions. I don't have to chase the dope man down. I don't have to resort to nefarious acts to get money. I get to choose how I live as opposed to letting my addiction choose how I live. And so, feel free to reach out with questions regarding this part, and we'll talk more after as well. But Scott Simpson is one of the co-principal investigators on this grant, and he couldn't be here tonight, or maybe he's here now, and I don't know, but he has jury duty. So with that, thank you all for your time, and I'm going to hand it over to JJ. And JJ, if you want to kind of speak to your experience and yeah, how we can help people best.
Yeah, awesome. Thanks, Katie. Yeah, just so my name's JJ. Been working at Denver Health, sort of consulting, and now full time for a whole year now. Working on this project together. I'm someone who's in long-term recovery from methamphetamine use. It's been 4 years now, and I the great thing about working on this project together is to see, that there are, people who believe that, people can heal from this. And the great thing is, contingency management has really just opened my own eyes on seeing people get together in a group setting. I think we started contingency management groups last April with one of our licensed addiction counselors, CC4J. So we get to run this in a setting where we have a peer support specialist and a licensed addiction counselor. And so getting sort of the feedback from both of those together with people in group who show up and, to speak a little bit more sort of how this program works is, they'll show up week 1 and we'll get one single spin on this wheel. And we incentivize them in 3 ways. We incentivize them through attendance, recovery focused activities, and negative UAs. So they'll get one single spin for showing up on week 1, but then if they show up for 6 weeks in a row, they'll get 6 spins on this wheel, plus additional spins for every recovery focused activity that they've done over the past week. And so they'll show up and they'll tell us, I checked into an AA meeting for the first time, I got a sponsor, I reconnected with an old loved one, I went to some more support groups here on campus, and so any type of extra activities will give them extra spins, up to 4 extra spins per week. And so at the end of the 16-week program, we'll have some people who will, we actually had just someone who graduated this past week who did not miss a single week of the program and started off with positive UAs sort of the first sort of 5 or 6 weeks of the program, and then has dropped negative UAs every single week for the last 6 weeks of the program. And this person has had so much support just from us, but especially from the other people around him, just like cheering him on. And so you get it, all the other participants who get motivated themselves by seeing other people, going through this program and reconnecting with loved ones, with family, and just showing them hope and something that, this drug is a very, very difficult drug to quit. And it's just so amazing to see other people in group together, inspiring each other, exchanging phone numbers, baking birthday cakes for each other. And, so this group has been just such a special thing to see. And I think one of the things that I think we were getting some, sort of like people saying, oh, but what if they just show up for the money and spend that on drugs? Well, they're showing up, and it's just getting their foot in the door. And it's, if they show up for 2-3 weeks in a row, and then we have people like this patient who just graduated the 16-week program by not missing a single week. We're rebuilding that, we're helping them sort of rewire that system and saying, we're committed to their treatment, but then committed to themselves. And something as simple as like telling these people that, we're able to start, talking about life skills, talking about budgeting, talking about getting, looking for their first part-time job potentially that they haven't had in years. And so it's really fabulous thing to attest to, is just seeing that, people are getting into treatment by hearing other people's life experiences. And so it's just been such an awesome thing. And I think what we like to do sort of at the end, if you have any questions for me with my experience with my meth use, or how I'm able to sort of help, connect other people, happy to answer questions that anyone might have.
And I do see one question in the chat.
Yeah,
Should I go ahead and answer that, Michaela?
go right ahead. Yeah.
Okay, so the question is, how do you tell the difference in the ER between psychosis from meth and psychosis from other issues like schizophrenia or mania, etc.? And I think sometimes we don't know, right? We do our best, right? We try and gather as good of a history as possible from the patient, their clinical presentation, can speak to it, if their vitals, if they're tachycardic or other things. We do a urine drug screen when possible, getting history from others, right? But I think sometimes it's just it's unspecified, right? And we want to figure it out, but sometimes it's not till they're kind of further down the line in that treatment continuum that we kind of figure out what it is exactly, right? So if they have to go inpatient or if they have to stay for a little bit in the emergency department, just till we can try and get more information. But yeah.
Awesome. So I encourage folks to keep dropping questions in the chat and want to thank you both. I have a question of my own, this being Care Not Cuffs. According to the Pew Charitable Trust, between 2015 and 2019, arrests for methamphetamine possession rose by 79% in the United States. Could you speak to the impact of criminalizing substance use conditions and how Beat Meth's research may help reframe our approach to substance use as a public health-based rather than criminal justice-based one?
Yeah, I mean, I think, and JJ, speak up after me if you have more to add, but, I think unfortunately with incarceration, people aren't getting access to things like contingency management, right? Or, I mean, a lot of even, for opioid use disorder like Suboxone and Methadone, people aren't getting connected to those services, right? And we see all the time that even if maybe they do get Suboxone or Methadone in the jails, as soon as they're discharged, they're not connected to services to keep that, right? And so, which is really unfortunate, right? And and like you saw in the presentation, right? There are actual changes in the brain that make this substance very difficult to stop using, right? Is and there's a lot of negative outcomes that come from being intoxicated with methamphetamine that maybe lead to incarceration, right? And so, yeah, if we can, whatever we can do to kind of keep people out of jails and keep them in treatment, I think is obviously really important. I mean, another thing with contingency management in particular, right? There's a lot of stigma around that intervention in general, right? Because you're kind of paying, right? There's a monetary incentive, and so people are like, oh, we're just paying people not to use drugs and things like that, even though that's still much less expensive than emergency department visits or hospital stays or maybe incarceration as well, right? And it shows it is effective and there's a science behind it. So, but because of that, like, for example, I believe in Colorado, like Medicaid doesn't support it, right? So, and how do we kind of make that more available to patients? I don't know, was that a two-part question? I don't know if I answered all of it, but.
You got it. Yeah.
Did we lose JJ? I don't know.
Yeah, we might have lost JJ. I'll be on the lookout to see if he's able to reconnect.
Okay.
Yeah, we'll give it another minute or so. See if there's any additional questions. Um, I guess it's possible we have a quiet group tonight, or all the questions they have might have been answered. But if you find yourself having questions later, we have contact information on the screen. So please reach out. And yeah, want to thank you, Dr. Camfield and JJ, for sharing your time and expertise with us tonight, and thank everyone for joining us. Again, we want to encourage folks to take a few minutes to write to your representatives using the resources on our website that are also linked in the chat. And we also hope you will join us again on May 23rd for our next webinar and discussion on the history of mental illness, deinstitutionalization, and mass incarceration as part of our Mental Health Awareness Month programming. And I hope everyone has a wonderful evening.
Thank you for having us. Really appreciate
Thank you.
it.